Welcome to another episode of the Move You Podcast, the official Fix Yo Shit show, where we're talking about how to fix your shit and also the shit show that you're in or that's out there and how to navigate through that. And today, I'm so excited to have Dr. Michael Rintala here with me.
Thank you.
I respected your work for 15 years. I knew of you when I was a student.
Wow.
Yeah, I knew of you through when I was in 2009. I was at Palmer, 2008-9. I was at Palmer, Iowa, and I was in the sports injury department. And that's where I learned about DNS and learned about you. And I saw some people working cross crawl patterns with different pressure points. And I saw like Bell's palsy reverse instantly with my eyes.
Right.
And that's where I learned about joint centration.
Right.
And so I heard about your name, and you have one of the best track records I know. I mean, you're professional. Your track record working with the PGA Tour, the World Surf League, private practice teaches. Dr. Michael Rintala teaches for Prague School of Rehabilitation. Mm-hmm. There's only a few teachers here in the country. So, I mean, unbelievable education. So much of Move You, joint centration that I teach actually is derived from the Prague School. They've been around since probably the 70s or so.
The school was established 1940s, I believe.
1940s. Holy cow. Really?
Yeah.
Wow. Because they were the original, because it consisted of like a multidisciplinary, didn't it?
Yeah, they were kind of the pioneers or the fathers of functional rehabilitation. So you had kind of the legends of functional rehabilitation, Dr. Yonda, Dr. Levitt, Professor Vojta. They're all neurologists, pediatric neurologists. And so their experience working with patients and all populations, they kind of started that functional rehabilitation evolution or focus.
What was before that?
So a lot of with rehabilitation. I mean, I'm a chiropractor, right? You're a chiropractor. Yep. My knowledge of physical therapy, and these are all physios, physical therapists. Actually, Yonda, Levitt, Vojta, they're all neurologists. But they were manual. I mean, they used their hands. So they were like physiotherapists, neurologists, and they used their hands and their eyes to diagnose and to treat. So, prior to that, I think focus was more orthopedic, right? Just joint focused and, ranges of motion, biomechanics. Whereas Prague School, starting in the 1940s, maybe 1940s, early 50s, with their background in neurology, they brought in more of the brain, right? The brain function, because the brain controls the musculature, which controls joint function, which allows us to move. So you had, at that time, these pioneers in that kind of approach, all kind of working together, Eastern Europe, so behind the wall, and just, again, utilizing their hands and their eyes and their knowledge to assess and treat functionally, which when I started to learn about them, that clicked for me. It made sense. And in chiropractic school, that's what I started to focus on.
Oh, you did too in chiropractic school?
Yeah.
Did you? Because I was also in there. I was, subluxation, joint alignment, honestly never really resonated too much with me.
Yeah. Like, in school, right? You're getting all the basic sciences, the anatomy, the cadavers, everything. And, as I was going through that, I'm like, great, a lot of good knowledge. You learn how to assess orthopedically, neurologic assessment, manual techniques. But I always had a sense that something was missing. And not until a rehabilitation course that they introduced Prague School of Rehabilitation and the way that they were thinking and approaching things. Once I saw that, I'm like, that makes sense, right?
What was it that made sense?
Just how they we're looking again at the brain's influence on synergy coordination of the deep stabilizing system of the spine, and that then translating into the coordination of all the musculature that runs throughout the chain of movement. If you have synergy coordination and timing of that musculature throughout the chain of movement, and you're working off of a stable base through the trunk and the pelvis, the core, then that then creates optimal joint position throughout dynamic movement or joint centration.
And if I could pause this thing. So everyone, we're going to be trying to stick on the topic of, I know a lot of you might have issues, disc bulge, disc herniation, hip impingement. And so we're going to be diving into different postural misalignments. And I think the deep stabilizers you're talking about are going to be, you're talking about diaphragm, transverse abdominis, pelvic floor.
Yes.
Maybe even getting anything else, the deep stabilizers.
Yeah. So, diaphragm, which is instigator, pelvic floor, the entire abdominal wall. So six-pack muscles, your oblique slings, the transverse abdominis, but also the intersegmental spinal musculature that runs throughout the spine. When that's on point, which means your nervous system and your brain is on point with facilitating that coordinated activity, that creates ideal, optimal core stabilization, which then allows optimal transfer and load of force throughout your body.
And I think we talked, please let me know if you agree differently. And you guys might know this. And I was, if there's one thing I could teach, is a couple years ago, I was on that show, the Live with Mark and Kelly. It's like 3 million people. And I've spent like 60 hours preparing for the 6-minute bit. And I go, what is the one thing that I, like, if I could pick one, I'm looking at this whole world, a new audience. If I could teach one thing, what is it? And it is how to properly breathe.
Yes.
I call it core breathing to simplify it.
Good. Yeah.
And then I'd love to get into that with you guys, because pretty much most of you guys that have challenges with this, whether they don't like the posture, they're anterior, they're flat, they're not hip hinging, they have symptoms from these things.
Yes.
Disc issues, bulging herniations, sciatica, even hip impingements, these anterior tilt patterns, valgus knee, all of these common signs. Rooting back, with the programs that I've created for these people, many of them back and core related. I start with the breathing, but some of them in like knee, I try to give them more something that's relevant to them and like back them up to it.
Yeah.
But would you agree with that, with the breathing aspect of it?
Yeah.
And maybe you can get into trying to help everyone understand, maybe even take them through like a journey of proper breathing and how they should be breathing. I think that'd be helpful.
Yeah. So, I mentioned the deep stabilizing group of musculature: diaphragm, pelvic floor, entire abdominal wall, intersegmental spinal musculature. So the diaphragm's kind of the key instigator in facilitating the synergy and timing of activation of all that musculature. So diaphragm, 2 major roles, actually 3. 1, respiration, right? The diaphragm attaches lower 6 ribs, something called your xiphoid process, wraps around and attaches to the front part of the lumbar spine. So it's like this big dome or sheet of musculature. The lungs are on top of that. You have the heart right there. And with breathing, when we take a breath in, the diaphragm contracts and descends and spreads. And so as it drops and spreads, the lungs expand. Now air can come in. And then to exhale, the diaphragm recoils and the air comes out. So just like a simplified version of breathing, right? So breathing function, key role of the diaphragm.
Instigator, meaning it starts everything.
It starts with the breath, but also it starts postural function, meaning I think it's something like 400 milliseconds before any purposeful movement, before I pick up this can, before I start to get off the chair, pick up a weight, whatever it may be, 400 milliseconds before I even start to move, the diaphragm will also drop, spread, and descend, and it creates a pressure that loads your pelvic floor, loads the entire abdominal wall. And if the brain is on point, then it reacts to that pressure.
So whether you're breathing or not, it should.
Yeah.
It should do these things.
Right. So there's the breathing function, then there's the postural function. So if I don't breathe and I go to lift this table, then it's all postural function. If I'm just sitting here, I want to take a breath, it's breathing function. But our brain has to coordinate between the two, meaning if we're walking, running, swimming, pick your activity, we need stability, but we also need to breathe. So the coordination of respiration and postural function or stabilizing function of the diaphragm as far as initiating that activity is controlled, and it's called the subcortical region of the brain or the central nervous system. Not to get too technical, but this region, it's not something that we think about every little thing. This is automatic. It's a program in our brain that as we move and react, it's providing the stability and it's providing us the ability to breathe while we move and stabilize. So that coordination, if that's working properly, then we have nice stabilization throughout full ranges of motion. So full flexion, full extension, throwing, running, again, whatever.
What does stabilization mean?
Stabilization means that that group of musculature is managing the pressure that was created by the diaphragm. And the better it manages the pressure, the better you can keep the core engaged. And when you're keeping it engaged properly, it stacks the pelvic floor, the diaphragm, all the way up to your called the soft palate, or we call it the oral fascial diaphragm. It lines up those diaphragms, whether you're laying down, seated, moving, running, whatever position.
The soft palate as well?
The soft palate and the just like thoracic outlet, you can consider those as a diaphragm. And there's also within the cranium, right? You have I forget the name of it, but there's structures that if we have this alignment, then when you create that alignment or that stacking, the central nervous system likes that, the brain likes that, and it expresses these inborn motor patterns that create that ideal coordination and stabilization. So when we talk about core stability, it's not just straight activation of the muscles, but it's dynamic, meaning you have the activation of the muscles, but you can still breathe and you can still move. We're not statues. We move, throughout life and with different activities. And the better that we can express those patterns in the brain to create that coordination, then the more efficient that core stabilization is. And with that efficient core stabilization, then you have your favorite thing, joint centration.
Joint centration.
And joint centration throughout full ranges of motion.
How would you define joint centration? Because for those of you guys that do know, maybe some of you know, but joint centration is like, I built so much of my methodology around the phrase of joint centration. I'm curious because I've been trying to refine it for years, because their original definition is a little bit complex even for me.
So to simplify it is you have a joint and you have muscles around that joint. And there's certain muscles, for example, like if I make a curling motion with my arm, my biceps and my triceps, if they're coordinated, one is contracting and the other is lengthening. If they're coordinated timing-wise, then you're able to maintain the position of the joint structures throughout that full range of motion. It could be the shoulder, it could be the knee, it could be the hip, it could be the little joints throughout the spine. So if the muscles that counter each other, one contracting, one relaxing, or one lengthening under tension, one contracting under tension, then the joint maintains an optimal position throughout that full range of motion, meaning it doesn't bang into the other joint structure, right, and start to beat up the joint itself.
I would say for you guys out there, a sign that your joints are not centrated, please elaborate if you need to, is that you have a tightness and a weakness somewhere.
Right.
You hear it. I have a tight back and I have weak abs. That's a sign of decentrated joints because they're not acting equally. It's not an equal game of tug of war. They're tight not because you need to stretch it more. They're tight because your body is out of alignment in a position the joints are decentrated, causing one side of the muscles to be in a short and tight position, the other side to be in a long and weak position. So that's just often, if you guys were my joints decentrated, you got a tightness and a weakness. And really, if you have pain somewhere too, a chronic pain, you're decentrated somewhere.
Yeah.
Would you agree with those?
Yeah. You've lost that coordination and timing of the muscles working together, and certain muscles are doing too much, and over time they adaptively shorten and tighten. The others become inhibited and weaken, and then you lose optimal joint position. You start to beat up the joint, or those muscles that are adaptively shortened and tighten create that tightness that you feel. And it's not necessarily something you just stretch it or you do some massage work. That's a good thing to do, but then you have to get the coordination back to create the coordination and the timing to create that optimal joint centration.
If we take something common like just every type of back pain, right? And this idea of weak core, weak glutes, which comes from what Yonda's lower cross.
Yes. Yeah.
Which, if you guys wonder about the Prague School of Rehab, I mean, some things have disseminated down that are common now. I would think the most prevalent amongst here is going to be upper and lower cross.
Yeah.
That's probably the most prevalent. Would you agree with that?
Yes.
So now what's happened is this: upper and lower cross comes in. Lower cross, and let's talk about it. People go, "Oh, I need to strengthen my core and my glutes."
Right.
And so, can you speak on that? Because everyone knows my opinion on what that actually means.
Right. So, you have the right idea. Yes, you want to have a strong core. You want the gluteal activity to be strong as well. But it needs to again be coordinated. So, if you have that coordination of diaphragm activity, managing the pressure that's created, which then allows all those muscles to be active and to provide the ideal stability, then you usually will see good glute activity. Mm. The synergy or the coordination of all the abdominal muscles, that coordination and synergy is really what provides the strength. But if you lose the timing, if you lose the coordination, then with like lower cross syndrome, you see certain muscles short and tighten. So hip flexors, extensors will adaptively shorten and tighten along with the fascia, which is the connective tissue. And then you'll see an inhibition of the lower abdominal region and gluteals, the gluteal muscles. So you can have a goal of like trying to isolate the glute or isolate the abs to get them stronger, great. But if they're not working all together, it's usually short-lived. And a lot of times you're strengthening the compensation pattern, which then overloads the low back or the hip. You lose timing, coordination through the chain of movement, so then maybe you feel it in the knee or the shoulder, or again, along that whole chain of movement.
When you say strengthening the compensation pattern, let's just say, for example, somebody has got this big anterior tilt. They're so long and weak. And what they can see is the rectus. So it looks like the rectus will pull it down. And let's say this person will be just literally, I'm going to do 1,000 crunches a day. Right. To fix this. And that, to me, doesn't seem like they're strengthening the compensation pattern. It seems like they're strengthening the weak pattern. However, they're saying, unless you want to dive into that, I would say strengthening please correct me if you see it differently. Strengthening compensation pattern for them would be focusing on hyperextensions when they're already extended.
Right. Yeah. So they end up accentuating the lower cross syndrome, or you can get stronger rectus doing the sit-ups, but all the other abdominal musculature is kind of left out in that strength component.
Right.
And then you lose the synergy, or like the symphony of activity that the brain provides to create that ideal stability and ideal alignment of the pelvis and your core, and then again all the way up through the spine. So as far as training or addressing that, you want to address those shortened, adaptive, tightened musculature. And you could do that with tissue work. You can do it with stretching. But then you have to wake up the awareness of the other muscles that are being inhibited, the glute, the lower abdominal region.
Do you feel the awareness trumps the strength and the mobility? Like if you could do you feel like that is basically the strength work and the mobility work and flexibility work is distant second to the coordination and retraining of the proper, let's just say, function of breathing?
Yes.
It doesn't give the instant relief, though. It's the long term.
Right. You can still target those areas with the stretching and the strengthening, but you need that base of coordination to be able to maintain it, to be able to maintain the strength and that you or the mobility that you utilize. Otherwise, it's just like a short fix, and then you revert back to the pattern that's creating the overall dysfunction.
To go back, why does this happen, though? Like, why is this, let's just say, lower cross? Is it because that one image that goes up, which shows short, weak, that people just go, oh, short, long, weak glutes, short, weak, or long abs? It didn't focus on the deep breathing. It's like, why are we continually now pushing this out? And still the theory out there, the misconception is I need to strengthen this and stretch that.
Right.
What's the evolution of this?
So the evolution of that type of imbalance, there's usually three kind of main things that will cause it. One is posture, sustained postures. So sustained seated postures, sustained standing postures. With those sustained postures, that alone will create the shortening and tightness. And the musculature, it also will change the breathing patterns. And if the breathing pattern is altered, then the stabilizing pattern is altered.
Sustained
postures.
Yep.
Repetitive movements.
Yep.
So pick your sport: running, biking, swimming, pitching, within all activities, or what I call occupational athletes. They're sitting at a desk on the computer all day, right?
Occupational, right.
Postures. So sustained postures along with the repetitive movements. Now with the repetitive movements, if you're always going to certain musculature and other musculature is inhibited, now you're decentrating the joint structures and you're creating overload. So sustained postures, repetitive movements, and the big one that also throws off the timing of and the coordination of the activation of the core is any past injury or pain. That will create a guarding or a high threshold compensation pattern that our brains and our bodies were designed to compensate. But it's meant for like a short-term survival thing, right?
The body didn't build us into one to take us back to where it was before the injury.
Right.
So it's not built in. That part's not built in.
If I hurt my leg and let's say I'm a caveman, I know the timeline doesn't work, but I hurt my leg, a dinosaur's chasing me, I find a way to move, right? And so the body adapts, it's like a survival mechanism. Problem is, if that compensation is what you're going to all the time, and you aren't able to get back to the ideal expression of the brain and the ideal motor patterns of coordinated activity, then you start to feel it. And usually the areas you feel it are low back, the mid back, where the mid back and low back come together. where your neck and the upper back come together. These are all transitional areas.
The transitional areas.
Yeah. And, for you and I, when we look at MRIs and X-rays, where do we see all the degenerative changes?
Yeah, L5S1, C6, C7.
Yeah. So,
not really too much at TL junction.
not so much, but more of the, cervical thoracic and L5S1. But what you do see with the thoracic area and with the hips is with those imbalances, you'll see loss of mobility through the thoracic cage or the thoracic spine. And you'll see loss of mobility through the hip. And if you're not getting mobility through those two areas, where does it go? Right?
Got to go to the
Back to
joints
those-
above and below at the top.
And then take that out into the extremities, shoulder, elbow, wrist, or knee. So that trunk and pelvis coordination and stability, if you have that joint centration radiates throughout the whole body. If you don't have the coordination of the core through the trunk and pelvis, then that decentration also radiates.
Is there a central point? Because let's just say somebody's like, I have, my feet are flat, my right foot's flat.
Right.
Or I have forward head posture, or someone has scoliosis. Is there, at what point do you start? Is there a central point to disseminate outwards, or is it from the injury back to the central point?
Right. So when you're addressing those things, and some things are structural, but like for scoliosis, for example, or let's say you have a degenerative hip or you have degenerative changes throughout the spine. If you can create a better environment of that coordinated activity of all the musculature and the core activity, then that improved environment decreases the wear and tear in those areas, even if there is structural changes. But as far as addressing it, you can go from inside out, meaning diaphragm activity, coordination of stability through the trunk and the pelvis, but also you need to think about support function of the foot, of the hand, because that has input into the brain and helps maintain the ideal stability. So usually you want to address it from both sides.
Both sides.
Both ways, from the extremity, but then also from the center. So depending on what the issue is, if you assess and evaluate, you can see the pattern and plus their history, right? Do they have an ankle sprain or chronic ankle sprain or flat feet or whatever the issue may be? You can pick and choose which way you want to come at it, or both. Usually you want to do both ways, but sometimes it's better to start with the support of the feet or the hands, or address the breathing.
Yeah.
But usually you want to combine the two.
I think it's safe. Yeah, that's a good approach. Is to combine the two.
Yeah.
That's a challenge I have with because I do much digitally, right? How do I? Because I have to connect with people where they are now, what they're used to. Unfortunately, people come to me and you with X-rays and MRIs and to change their whole dynamic to something about breathing from this.
Right.
Can sometimes be an uphill battle, opposed to giving them something's going to help them feel good, to get them to see the light a little bit, to guide them to what they need.
Yeah. Like if you, and especially working digitally, right? If you cue them properly and if you show how to create the right support, or you talk them through the ideal breathing pattern, that can be huge. So, when they're in person as a clinician, I can use manual methods to help with that and help them feel it. Because the big component of when you're addressing these compensatory patterns and they've lost the timing of the core stabilization is if you can position them in a way that helps create the ideal activity and they feel that, a little light goes off.
How would you because this stuff right here we're talking about, I know some people are like, oh my goodness, coordinating all these
Right,
things.
right,
It sounds
right.
like they're learning to be a ballerina or something.
Right.
And so when we talk about just the breathing, are there some key positions that you find? Like, what are the key
Yeah.
positions let's just say the positions you find that most people respond to the fastest
Yeah.
with reprogramming the way to
Yeah.
breathe?
So two go-to positions to get the feel of ideal breathing. One, you can lay on your back. And when you lay on your back, if you bend your knees, you have your feet on the ground, and let's say you put one hand on your chest and one hand below your belly button. If you then breathe in through your nose, ideally, you're going to feel the initiation of the breath in the bottom hand, the hand at the belly button or just below. If that's happening, then you know the diaphragm's dropping down and working in a fairly functional way. If you take the breath in and there's no movement in the bottom hand, but you feel everything come up into the neck and chest, that then tells me that the diaphragm's inhibited. It's not able to descend. So your brain is then asking what's called the accessory breathing muscles, the muscles of the neck, shoulder, and chest, which then lift the chest to try to get the expansion of the lungs, to get the air. And those, when those muscles are doing all the work, that means they're 20,000 plus times a day that we breathe, everything's coming up into the neck and shoulders. So all your headache patients, all your shoulder and neck pain patients, that's usually going to be a component of the underlying pattern that's playing into a lot of the chronic stuff. So just laying on the ground in that position and working on feeling, trying to get the feel of the diaphragm dropping and coming into the bottom hand and keeping the top hand quiet can be a great start in improving that breathing function.
Are we born breathing properly?
When we're first born, our brain is still forming, right? Our nervous system is still forming. Our joints are still forming. And for the first 6 to 8 weeks, we're pretty uncoordinated. If we move, the whole body moves. Our breathing, we're not getting the ideal activity. But by 3 months of developing as an infant, if our brains are healthy with that development, at 3 months, that coordination kicks in. And when the coordination kicks in, it acts like the way I described with the diaphragm dropping, and it does that with both respiration, but also stabilization. And then what happens in that first year of life, usually 3 months to maybe 16, 18 months, is that quality of breathing and stabilization gets better and better. So you see the infant able to slowly attain higher positions and eventually come to walking. And this is all being expressed, with the brain.
Oh, so this
and
breathing,
with
the breathing is a long development as well.
Breathing and stabilization. That period of time is where your postural foundations are established. So it's real important to have a good environment to develop and a healthy brain or healthy central nervous system. If you don't have that healthy central nervous system, then you see dysfunction, and it can progress. And there's different pathologies that you see with the infant, and then it has consequences later on. But that's where the central nervous system, the brain, is expressing itself, and those again, where your posture is established. But then what happens if we have that, as adults, we sit too much, we move in repetitive patterns.
I was going to ask you, where do we lose it?
Yeah. Usually right when we start sitting in school, right? Kids.
Is it because we sit, or maybe our stomach contents are pressed up?
Yeah. So with the sustained seated postures are a big issue. If we're sitting here, we're sitting upright. Give it a minute or two, and gravity is going to start to win. So we
Right.
start
If you're
to
going into
slouch.
flexion here and slouch.
Yeah. So the forward head posture, we slouch. That alone inhibits the diaphragm descending. So what's your brain going to do? It's like, oh, I'm going to use my neck and shoulder muscles to get the oxygen that I need, right? So
yeah, that logically makes so much sense.
Yeah.
It's just you slouch, everything's compressed there's so much compression in here.
And then you can't
The
get
diaphragm's
the
like, I
expansion.
can't push down that hard.
That's why it's important to try to create, variability or get up and move as much as you can. Or if you are sitting constantly throughout the day, just taking a break, sitting up. You can put your hand below the belly button, hand on the chest. You can work the breathing for a few seconds, relax, and then go back to your activity. So if you can counter those sustained postures, then you can minimize the effects. But, going back to where does it start, you see that a lot of breathing dysfunction with young kids when they, kindergarten, first grade, et cetera, when they start sitting all the time. So, and then the other thing, especially with young kids, especially, we deal with a lot of athletes, and there's a lot of club sports. Sport is great, good activity, good exercise, but if they're doing the same movements over and over, now you have those repetitive movements. They've been sitting in school all day, then they get out and they do the repetitive movements, and you're starting those patterns of compensation and overload. And then eventually they get hurt, right? With the young kids, it's usually an overuse injury, the knees, the back, the shoulder, whatever the activity may be.
Do you like that word overuse, or do you think if they were in proper alignment, they would not present the symptoms of overuse?
Good point. Yeah. If they have the right coordination, then even though they're doing a lot, they're not overloading these areas. So,
right. So I've never liked that word overuse.
Yeah, no, that's a good point. So a lot of that comes down to, can we give the kids enough breaks in school to move? And I think in Finland, what is it? They sit in class for like 45 minutes, then they move for 15 minutes, right? Every hour. So certain systems have the right idea. And you look at the tests or the success as far as school systems and systems like that.
Well, Big Pharma certainly wouldn't be a proponent of that new system.
No,
they're tapping into future revenue.
Right. Then you don't have pain that you have to medicate.
Yeah, what the heck?
Right,
no.
Right.
We're gonna buy them better desks. That's what they're gonna invest in.
And we need more time in school, not more time in play.
Right, more time in school. Yeah.
So
assholes.
Yeah. So if you can, there's a whole, I teach dynamic neuromuscular stabilization, and we've actually developed a course called Dynamic Neuromuscular Stabilization. It's short for DNS. We call it DNS Fit Kids. And it's a whole strategy of integrating ideal movement, breathing, and stabilization into this population, because that's where it starts.
Do you work with TPI at all? Have you worked with them? About their junior programming?
I've taken some of the coursework, and it's excellent.
Yeah.
And they talk about this too. They talk about variability of movement,
right,
and not specializing too early. With young kids, it's like don't have them specialize in just soccer or tennis or golf. Have them play everything, so they're varying their movements. And so they're TPI, which their system, FMS, SFMA, really good evaluation systems. If you go back to the roots, it's going back to upper cross and lower cross, right? And then finding where you need joint stability and joint mobility. So there's the roots of that fall into that functional rehabilitation model.
You know what? Now that we're in the roots of that, because we've been talking about breathing, compensation, a little upper crust, a little lower crust. But I think what will be relevant for people is and maybe you are in agreement with me or see something different, is I call them common postural misalignments. And I think you call them postural syndromes.
Right.
And almost like these developed common syndromes. Like, for example, for me, I see an S-shaped spine, anterior tilt, kyphosis head. Yes. I see a flat spine.
Yep.
And of course, then you have an uneven spine, which is uneven hips, uneven shoulders, which we can classify scoliosis past a certain degree. Mm-hmm. Then we have this valgus collapse, flat foot. And I tend to think that those are like, I've lumped those into the most common, and a lot of the work that I do is help people identify those and reverse out of them. Good. But I don't know if you see something different with common types, because we got the breathing aspect, but maybe like if we're sitting, yes, the diaphragm, but how does that connect with how the posture is affected, the whole body posture is affected? Yeah. Maybe you could tap into those.
Yeah. So 2 common postures that you'll tend to see are postural syndromes or positions. One, we call it the scissored position, meaning the hips are tilted forward, the chest is coming up into that. We call it an inspiratory position. And with those 2 positions, you lose the stacking of the pelvic floor and the diaphragm, and you get an opening.
Oh, it's interesting with the stacking. You're saying because the stacking is they should work on down and up. But when they're open, now there's an angle, and it's got to pop out the front.
So it either pops out the front, so you'll see the distended belly and the weakness in the lower abs, so that's stretch weakness. And then you'll see the extensors in the back are just
hanging on
and tighten. So that's the scissoring position. And then the other common one, and this is common with your high schoolers, right? It's the slouched. So their forward head posture, we call it a kyphosis, but it's the curve in the thoracic spine. And that's going to play into upper cross, which is the tightness of the neck muscles and the neck and shoulder stabilizers. So you have certain muscles get weak, certain muscles get overused. So those are 2 common postural syndromes, which then create the overloading, which we talked about, or the decentration. And for both of those, you want to work on getting that alignment back. The pelvis, the thoracic cage, the rib cage, and then also the head posture. You do that, your brain likes it, and it's able to express those patterns that we're born with more effectively.
And tell me about, let's talk about the scissoring pattern. I see that being the most, not this scissoring. Okay? I'm seeing this being the most prevalent. I created a set of calipers, and I've measured pelvic tilt on thousands, right? And I measure on everybody.
Yeah.
And it's interesting. The findings is about 70% of people are in this more anterior, and I call that usually about over 12 degrees on the left-hand side.
Right.
And so now you have this position, and I'd like to know what if you found correlation with this, because this is what I've seen with myself personally in research, is this position, this hyperextension scissored position. You're now, yes, the muscles are short, but now you're compressing the joints in the back. Yes. You're compressing the SI joints as well. So over the course of time now, you're going to have osteoarthritis form, and ultimately then spinal stenosis, even into hip impingement, because when your extension, that anterior labor, that acetabulum covers the head, and so that thigh comes up and whacks it.
Yep.
And so now these people, what they do is they're running to the doctor. They're getting x-rays to go, this is what I have. And I go, I don't need an x-ray to see that.
Yeah.
I barely even order x-rays and MRIs anymore, ever.
Yeah.
I know what's going on.
Right. You can see the position, you can watch them move, and you can tell what's tight, what's weak, and it'll play usually into the symptoms.
Based on their age, usually, if it's just going down, if it's working on that classical scale.
Yes.
Do you find that as well?
Yes.
You do.
So with the the anterior pelvic tilt, again, so for example, I live up in Solana Beach, kind of Del Mar area, which is North County, San Diego.
Beautiful place, by the way, Solana.
And every year they have the CrossFit Games.
All right.
CrossFit, great, great exercise, great sport. Nothing wrong with CrossFit, but it is a sport.
Sure.
And it's designed to push your limits, right? And if you're constantly pushing your limits past your capacity to keep that alignment, then especially with, again, weightlifters, you see overactivity of the hip flexors and overactivity of the extensors. So I'll be in Whole Foods up there, and I know when they're in town because there's a bunch of super fit, really jacked people walking around with anterior pelvic tilt,
Right.
flared rib cage, and you can just see that activity. And part of that sport is when that happens, we call it they're falling into the functional gap, which means they're utilizing a compensatory pattern to get the job done.
Functional gap,
which again we're designed to do. The functional capacity is the ability to maintain the coordination. So with athletes, occupational athletes, humans, everybody has a certain capacity to keep that ideal alignment and stacking and coordination. If we go past that, we fall into compensation. If we just occasionally go into compensation, it's not so bad, right? We can come back to the ideal stacking. But if we are constantly training and working in the functional gap, the compensation pattern, then we see the scissoring, the open scissored posture. Or with the slouching, kids sitting in school all day or people in front of their computers all day, you'll see that adaptation or that postural syndrome become an issue. So if you can address both those syndromes, then for that CrossFit athlete, they create durability and longevity. They don't beat up those areas throughout the body. For the person who's sitting in front of the computer all day, you counter that posture, you improve the breathing, and you don't create the overload, usually for those people in the neck and shoulder region. Yeah.
Now, the other one is the common one that I see is this flattened lumbar position.
Mm-hmm.
I'm always like, is the root of it they don't know how to hip hinge? So I'm always helping them get back to hinging, work on spinal extension. Now, that overload, those people that out there, they go, their pants are falling down, they have no butt, they wonder why their back, they got these huge erectors, all gut, no butt, their erectors are huge in their back.
Yes.
And their spinal flexors and extenders, like a paper clip to the max. And those people, it's predictable. I'm like, you're likely to bulge, herniate a disc because you're the disc. And the question then is on the disc end of it, it goes, so the resting position is on their discs.
Right.
And please, I'd love to hear your side on this one too.
Yeah.
They rest on there. Their position of their spine, I'm like, is their position of spine like that because they never learn how to hinge and therefore they're always into flexion, so therefore they are in flexion.
Right. Yeah. Yeah. If you're constantly in flexion in the lumbar spine, you're just asking for a disc pathology or disc problem. So with hip hinge or a squat or kind of deadlift or any movement, we want to be moving through the hips. We want to be moving through the ankles, the knees, and the thoracic spine. And what happens, again, with sustained postures and the other things that throw off the coordination is we lose the awareness of being able to move through the joints that we're supposed to be moving through. And instead, if we can't find that hip hinge, we lose that coordination, then it goes somewhere else. And it's usually, again, low back will take up the slack. And then if you're repetitively flexing, extending, or over flexing through that region, the disc just wears out, and you get the little tears or micro tears, and then the fluid inside starts to work its way out, and you get the disc bulging or other things. So it comes back to, can you teach them or help them feel how to move properly?
And also the fastest way to get them to do that.
Yes. Yeah.
And I'd like to know what you think is the because I'm ultimately trying to help people get the results as fast as possible. But the challenge is we're really trying to get them to change behavior and coordination.
Yeah.
And it's not a stretch. The number one thing, what's the best stretch for this? Well, I'm like, what's the best? It is back to I want one thing that'll do everything.
Right. So hip hinge is king, right? If you can get them moving through the hips, you are activating glute, you're usually activating core, and you're creating the ideal alignment, and you're getting the coordination back. The problem is if they've been in those compensation patterns long enough, they lose the awareness. It goes to sleep in the brain. So if you can show them how to move, so for example, hip hinge, a good go-to is they'll be on their hands and knees, and now just rocking a little bit back and forth. You want them moving through the hip, the shoulder, and the knee. And if they can start small and start to get that movement, then they're going to help increase their awareness and start moving in the direction that you want them to be moving. So taking them into those lower positions, like hands and knees, first trying to start in a squat position, because if we're standing, it's like the highest, most unstable position, and there's so many ways to compensate and escape. So a lot of times we'll bring them down into hands and knees.
Escape, yeah, that's right.
They'll escape into the back or into those compensation patterns. So if we start them on the ground and start that rocking, and either verbally cue them on how to do that, or if they're in person, help them feel it and move through the ideal position, you wake up the brain, and then you wake up the coordination. So usually to address that, I'll start them in those lower positions. And then once you help them feel the movement, you can then also integrate the breathing and the stabilizing function through the core, and then have them keep that and move at the same time. So there's progressions that you go through to help with the awareness, whether it's talking them through it or in person using your...
Have you found any tools I forget where, I didn't even put it on. I was at some event and they were like, no, this is a brain stimulator. You put it on, it's like electrical. I'm like, I'm not putting that on, but maybe something like that, because I feel what the world needs is basic, because I see so many comments and just see so much volume is people, they have pain. And unfortunately, many times we got to wait for them to get to that level to do anything, which sucks. But when they do, or they have a postural sign that they see before pain, great, that's better at least. Now we can wait for it to turn into that.
Yeah.
And these people go, I need more strength, or I need more mobility, or I need more flexibility, or I need an exercise. I personally think the one thing that people need is awareness.
Yes.
Of their body position.
Yeah.
And I actually coined a term. It's called positional presence, and it's a constant state of awareness to the alignment of your body.
Nice.
Because proprioception, I'm like, what is that for people? It's like awareness of what?
Right.
Positional presence is awareness to the alignment of the joints in your body.
Yeah.
Joint centration is alignment to a joint.
Right.
And positional presence is awareness of that alignment of the joint.
Yeah.
And so I think my question to you is, I kind of want to share that with you too, positional presence. I thought you might like that.
Good. I like it. Yeah.
Okay.
Yeah.
Is like, to get people to this awareness, like, what do you realistically think is because we're dealing with a culture that, like, getting people and training and doing all these things, it's like, we want to get them the fastest result. Like, the aha moment as fast as possible.
Yeah.
Have you found we went over some patterns, but any tools, like even getting back into DNS stuff. I don't even remember what the hell was going on, but I remember this the guy, I forget what his name was. He was our DNS instructor, tall guy, thin, Yurja. He was a Palmer. But he had people in like cross crawl patterns.
Yeah.
He had like 4 people applying pressure points.
Yeah.
And I'm like, this looks too boring for me to do. But I saw results with it.
Right. So what you're talking about with that's one of the founders of Prague School of Rehabilitation was Václav Vojta, who was a pediatric neurologist. And he one of his specialty groups that he worked with was cerebral palsy. Cerebral palsy usually happens at birth. There's a lesion in the brain, and when that lesion occurs, you're not able to express those motor patterns, right? Go through create those postural foundations. So he developed ways he recognized early on, taking the infant, looking at the infant's reflexes, natural movements, putting the infant into positions and looking at reactions. He could tell early on if there was that pathology. And then from there, he started to, he's one of the geniuses that just kind of figured out ways, how can I help these kids, right?
Right.
He started playing with, his knowledge of developmental kinesiology, which is, development during the first year of life. Looking at that, he started he found these points of support, or he would emphasize these points of support along the rib cage, along where the infant's supporting on the elbows, on the glute, on the back. And he started playing with pressure and kind of vector of thinking about how things are loading. And he found that with that application, he could light up the central nervous system, the brain, help it express those inborn hardwired motor patterns, and with neuroplasticity, which is the ability of the central nervous system to adapt, work the motor patterns around the lesions. And it wasn't a cure for cerebral palsy, but he found that if he did that, and the earlier he started, it could be the difference of being wheelchair bound or at least being able to ambulate, right? So it's called reflex locomotion.
Right.
Yeah.
Right.
And so
that's what it is.
Yeah. Reflex locomotion. So especially with the infant population, and in Prague School, there's specialists for pediatrics, and they also use it with spinal cord injury.
Is Prague School still going and everything?
Oh, yeah. Oh, it's evolved.
I messaged you years ago. I was in Prague for like one night, and I'm like, wait, Prague School of Rehab. Remember you tried to connect with somebody, but they wasn't. I can't make
So
it.
you had Prague School, and then Professor Kolaj, who's kind of the developer of DNS, dynamic neuromuscular stabilization. He was there. He was Vojta, Yanda, Levitt, the founders of Prague School of Rehabilitation. He was their student, then their colleague. Those guys was his mentor. So he's evolved into what is now DNS. So, but there's whole units that deal with pediatrics or spinal cord injury or other pathologies, MS, et cetera. And they utilize those reflex points, because with infants, you can't tell them like, hey, breathe like this, right?
Right.
Hey, activate your core. They're they're not listening to you.
Right.
They're just reacting.
They're reacting.
But if you put them in positions and you provide optimal support, you see the central nervous system express itself more efficiently. So Vojta, with those reflex points, the reaction that he's creating, Professor Pavel Kolaj, who also specialized in cerebral palsy, he recognized that and then started integrating it into general population and especially sport. So not only just the reflex points, but the positions that are based off of development, certain developmental milestones, where you're loading in a way and positioning, going back into the positional presence. And if you position properly and you load properly in these different areas, you're lighting up that nervous system to create these patterns. So, and that's, you're lighting up the subcortical region of the brain, which is automatic. But then above the subcortical region, we're getting a little technical, but you have subcortical, then you have cortical. Cortical is where your body awareness, your fine motor skills, your learning comes in. And so if you can utilize optimal positioning, but then have the body awareness to feel the diaphragm activity, to feel the quality of support, to feel that the right coordination of activity, you combine those two, then you can really help people get that awareness back.
Oh, can you back that up a little bit? So now you said, because we went on layers with that, right? You said the first layer is subcortical.
Subcortical, yeah.
And we can stimulate. Subcortical is the center in which produces autonomic activities.
Automatic activity.
Automatic.
Just automatic expression of these inborn motor patterns.
And we can stimulate those through different pressure points.
Yeah, with Voita, certain pressure points and vector, but we can also do it by positioning, right? So,
and I guess, okay.
The better you align the pelvic floor, the diaphragm, head position, automatically those patterns.
Oh, that's a good
themselves.
cue.
Yeah.
That's a good cue.
So having the presence of the alignment automatically then fires up the part of the nervous system that is automatic.
Is it because maybe the base needs are taken care of and it can move on to higher levels?
The base support and the input from that base support allows that expression. And the expression is respiration and stabilization. And if you have that combination, the awareness of position, feeling optimal loading and position, then you get that automatic expression of coordination.
And when you say that, I just go, man, I'm like, the problem is that we have this society U.S. is so controlled by pharma, and there's so much money in that there's that's why I'm like, because why isn't that here? I'd love to look at more of the Prague society and like their financial system, because they don't want that here.
Right.
It is like the model, no, go to your pediatrician, go do these things, get more vaccines. It's like, to me, I'm like disappointed. I'm like, that seems like the limiter.
So if you go back, if we go back to the kind of the founding of Prague School of Rehabilitation, right? This was a group of neurologists who, again, this is back when the wall was still up. So that was Eastern Europe and communist rule. So if you look back to then, you look at the West, more technology, more pharmaceutical, right? That was the West's way of approaching pain or dysfunction. And here you have this group they don't maybe have those resources. So what do they have to rely on? Their eyes, their hands to feel. And so with that emphasis, they develop systems of assessment and system approaches for therapy.
A
so
resource.
You see the West, more drugs, more technology, which, again, there's a time and place for everything. But when we're talking about movement and core stabilization and ideal breathing, then there needs to be this component that the Prague School of Rehabilitation was addressing and creating and has evolved into the approach today, which is, again, dynamic. We call it dynamic neuromuscular stabilization.
Now, is Prague School, has Prague in Czech westernized, where basically Prague school is a lonely island now? Or is it relatively, accepted and part of the path to enter this form of this more natural form of rehabilitation?
In Prague and Europe in general, it's a more accepted approach. Prague or Czech Republic, I believe it's socialized medicine. So you don't have these investments in doing studies in manual methods, right? Like, how are you going to monetize that, so to speak, right? Where the pharmaceuticals, et cetera, you have a return on your investment, so to speak. So I think, one, just the culture that they kind of grew up with, and maybe the fact that it's socialized medicine and there's not the investment as you see in other things in the West, that there's the promotion.
I mean, do you get frustrated with that here? Do you see that here? I mean, because I'm like, you're teaching, there's only, I think, 18 Prague educators or so, not many of them. It's still, I mean, I've been out of school since 2009. I don't see much Prague here still.
Yeah. I was introduced to, I first went over to Prague in 2003, and that's when I saw Professor Kolaj, and I saw how he was thinking and approaching it. I'm like, finally, something makes sense. This is going to be everywhere in like 5 years.
Right.
20 plus years later, we've just scratched the surface.
Right.
And part of the problem, I think, is it's not like an easy fix, right?
Right.
You can't. It's not just a pill.
Right.
It takes work.
Right.
And it takes patience and work on the therapist's side, but also the patient's side. And you need to understand there's a process. There's a process how you develop the dysfunction. There's a process to get the more ideal function back.
There's a process into the situation you're in, and there's a process out of the situation you're in.
And it takes, and everybody, depending on their awareness and the skill of the practitioner, that can be a quicker process or a slower process. Not to say you can't integrate, more invasive procedures or pharmaceuticals, but there needs to be, each individual's process is going to be different and have different needs. But as far as Prague School, Professor Kolaj, and the DNS approach, creating the awareness and the coordination of the activity of the diaphragm and that deep stabilizing system, if we can do that, you see people get this nice momentum. They literally like pull themselves out of that pit of dysfunction, right?
It's how to get it, how to get into the point of the momentum, them feeling it.
Right. That's the trick. And that comes into your skill as far as verbally cueing. So like with, digital.
I tell people 30 days. I'm like, when you start 30 days in a row, 2 times a week.
How do you break a habit, right? Was it at least 21 days? Yeah, right there. And usually what you see, if people have good body awareness, you'll see a 3 to 5 week period of time where it'll start to click and they'll feel it, and then they can really progress nicely. People whose body awareness isn't ideal, they struggle with it, maybe 6 to 8 weeks, right? It's a little bit more of a process. And then once you have that, and you have the exercises, you have the presence of position.
Yeah.
You work the coordination of breathing and stabilization, that becomes part of your,
it's incorporated in your daily movement.
It's like brushing and flossing.
Sure. Well, I always tell people, like with the breathing aspect, core breathing, I mean, I don't just stand there and breathe. I get on my rower in the morning and I do 100 pulls. That's 100 breaths. Then I do in front of my mirror. I do my scapular work, but I'm doing the core breathing I'm getting 200-300 there. And then I'm in the cold plunge getting another 40. So I got 250 of those in 15 minutes.
Yes. And that's the thing. It's like,
but it's not extra work.
You don't need necessarily 2 hours. You can spend 5, usually 5 to 15 minutes once you get the feel of it. And now you're just constantly reinforcing that
Reinforcing the pattern.
And then you're creating durability and longevity as far as movement efficiency, so that when you're 80, 90, 100, you're still moving well. And it's, we talked earlier about Peter Attia. There's lifespan, and what's the other thing you call? Basically, it's like you don't want to just live to 100.
You want to live well.
You want to live well, right? Health span and lifespan.
Oh,
right?
okay, gotcha.
Yeah. So you want to be a healthy 80-year-old, 90-year-old. You want to be able to move well. And, there's other components, right? Nutrition, et cetera. So when I had the opportunity to work with Peter Attia, Dr. Attia, and he saw the DNS concepts and principles as the longevity, durability, movement component, right? He's focusing on nutrition and exercise and strengthening. But then the other component is movement quality, so that all those other things, you can enhance those effects. Because if you eat well, if you just get strong, but you're doing it on decentration or lack of coordinated movement, then you're going to get the bad hip, degenerative changes in the spine.
You could be strong
and
have those.
Now you're like a beat up 80-year-old, 90-year-old, whatever.
That's the tough for me to see. I think the challenge that I see is I see these patterns in somebody who is like, I have a labral tear in my hip.
Right.
And I'm seeing them in massive anterior. I'm seeing them go valgus in the knee, and I'm seeing them go in and elect to some procedure for the hip.
Right.
And I'm already knowing the outcome. Best case, it's mediocre for 3 to 5 years, and then it's back. And then it's another one.
Yep.
And now there becomes this reliance in healthcare where now it's almost like they're trying to condition you that your life is always going to be like this, or this is the way it is. So there's this acceptance of declining.
Yes.
And it's hard because I'm like, if we just put work 2 to 3 months of good work in now, like I still put the work in, but I put when I was younger, oh my God, it's hard. But I'm reaping those now. I tore my labrum a few years ago. I'm back in action 3 months. There's no surgery. I'm good to go. I feel I'm going to go.
Change the environment.
That's right. Yeah. And I focus on, instead of resting, icing, I just go, okay, I tore it. Let me just strengthen it. The one thing I tell people is and this is I'm working on this. It seems to be resonating with people. I go, like if I had to simplify it to people, I say, you need to strengthen and mobilize your body in the opposite direction of the misalignment. Mm-hmm. So if you're here, you got to strengthen and mobilize them. But that requires them to know what is alignment and then where they are, and then just close the gap.
Yes.
So this is what people are responding to that, because I just to normalize. Like I think we know now that with fitness, people are like, oh yeah, for fitness, it's a lifestyle. If I'm out of shape, I've got to work for it. Right. But that has not been properly in the world of our rehab, in our world. That's not accepted commonplace yet. I saw my PT 5 times. I saw them for 2 weeks. Right. I did chiro for a month. Yeah. I tried. That's the worst word if you ask me. What do you mean try?
Right.
There's no trying.
Right.
It's like about breathing. I'm like, is it going to work? I'm like, how could it not work?
Right.
You were improving this. How could that not work? It works.
Yeah.
And so I think that's like the normalcy, and where this conversation we're having, I'm just like, man, like how to create that to be the norm. But I feel like we've been against this big beast of pharma and med. There's been so many trillions of dollars shoving down against us. That is, by the way, I bank off of them. That is my frustration point that I kick off of to get some energy.
Right. Well, just as a culture, we want the quick fix, right? We want the pill. We want the surgery.
Ozempic now.
Yeah. So, and, all the time, I'll see patients that get low back surgery. They clean up the disc or whatever the fusion, and the surgery was a success. And I say in quotes, but if you did not change the underlying pattern that got you there, it's 3 months, a year, or later. Now the
same level above it, same level.
It's back.
Of course, it's back.
So
I can't believe it lasts that long.
Right.
I'm more surprised by the people that it actually lasts for years.
Yes. And they just have great capacity to compensate, usually. But the point and the kind of the goal with what we're talking about is okay, let's say you have to get the surgery. Great, it relieved the pain, but now do the work to change the environment so you don't have to come back to that. Or most of the time, there can be disc pathology, the labrum. You change the coordination, you create the joint centration, pain's gone, you're functional, and you don't have to do the invasive work. There's time and place for everything. But if you can be proactive and recognize inefficient movement and overload and address that before the problem begins, then you avoid having to do these other more invasive interventions or rely on pharmaceuticals, et cetera.
And like we said in your podcast that I really like with Atia was that, like, not only that, but let's just compare athletics. These people like Federer, these guys, they are able to prevent these big injuries is because they know they have functional limits. They stay within them. They come out, they can come back to them, and then they keep themselves in this durable position.
Yes. Usually those athletes you see rise to the top of their sport, you watch them, they move so fluidly, so efficiently. They make it look effortless. And that's because they usually have good postural foundations, good, what we call cortical function or body awareness, great mindset, et cetera. And if you have that combination, you're moving efficiently. And you see, those athletes, the Federers, the Kelly Slaters in surfing, they get hurt, but they tend to get better quickly. And then you look at the, Tom Brady, et cetera, you look at the longevity of their career. They have this nice long career. You have other athletes who can still be successful, but if they don't have that combination of optimal posture and movement efficiency, they tend to get injured more, take longer to recover, and the career tends to be shorter.
Right.
So that's where the durability and longevity component of integrating these DNS concepts and principles comes into play. And those athletes, they're just naturally, they have it. And if they have the right training, the right nutrition, the right coaching, they maintain it. But it can go the other way, right? They may be amazing athletes, great postural foundations, great body awareness. But if the training, programming, the technique, coaching is not ideal, you can create dysfunction. You can create decentration. So that's why you need the importance of good coaching, good rehabilitation, good strength training. You get that nice combo, and TPI talks about that, right? Have a good team.
I think they've done the best job at integrating.
Yes.
I've never seen someone do better.
Yeah. It's
multi-professional, bring them together.
Great model. Yeah. And
great model. Yeah.
Great model, great work. And so, if you have that combination, then you're not messing up the athlete, or it doesn't have to be an athlete, right? Just if you're training just to stay in shape, have a good movement person, someone who can do, physio or a chiropractic, who has the knowledge of this, and a good strength and training coach. And ideally, they're all talking to each other to benefit you.
Like what I hear now is people always ask me about PRP, stem cells. And I'll say, please tell me what you think of this. I go, let's just take a hip labral tear, for example. What's interesting about hip osteoarthritis, labral tear, 97, 98% of the time, it's in the exact same portion of the hip. It's in that acetabulum. It's in the anterior medial aspect of it. And so it's obviously decentrated because it's banging into one aspect.
Yes.
When people are going, I have hip arthritis, really they say, I have hip arthritis on 1% of my hip, and the other 98% is fine. But that's not how it's said. But the point is they'll ask about PRP. I go, well, PRP and stem cells is amazing, but if you are going to try to inject that into an area that's decentrated and grinding, what do you really expect? Like
exactly.
You're outpacing your body's, first of all, you're outpacing your body's own ability to heal.
Yep.
And so then you throw in the stems that maybe a little bit faster, but ultimately you're going to grind it right off again.
Yeah.
Do you agree with that?
Yes, totally. And again, it's amazing, right? There's the peptides now, the stem cells, the PRP. Those are all great tools to address tissue injury and help regenerate. But again, if you're not addressing
What are you doing?
the cause and the underlying pattern, then and that stuff's not cheap.
Yeah. I mean, maybe
So
you could get it every 3 months forever.
Well, that's, yeah.
It grows, it wipes, it grows. Maybe.
Exactly. So there's that huge need to, if you do that intervention, great. But now add this layer of dynamic neuromuscular stabilization to enhance the effectiveness. I have pain medicine docs who send patients to me. They're doing great work with the injections, trying to help people.
They're doing great work. Okay.
But well, some of them, right? But if they have the knowledge what we're talking about,
If they're sending you people, I'll say that's the best work they're doing.
They see they see the gap, right? They see
okay.
And then with experience, right? They're injecting, it's not getting anywhere. Oh wait, this guy's talking about improving the overall environment and movement quality. Maybe we should try that. And then if you integrate it, now they start to have more success, right? You enhance, because again, some people they get to that point where you need that. Ideally, you get them here so they never get to that point, right? That's the ultimate goal.
But if you get people in chronic pain, and I do see the benefit of having a form of pain relief, because people get fears of movement and they can feel it. And then just to numb it, to get them into the movement.
Yes.
But the problem I see is that in theory, that sounds good. Most of the time they go, I'll do that. Then they take the pain med. They go, I feel fine. I'm back to what I'm doing.
Yes.
In theory, it sounds good.
Right. Well, how many times has this happened to you, right? And I find a patient comes in, they're flared up, low back. You get them better, and they're like, okay, great. And you're like, if you do these things, it won't happen again. I feel good. I'll let you know.
The signal's gone, back to what I was doing.
Yeah. 3 months later, 6 months later, flare up again. They come back in. Get them better. So, we can do things to prevent if you just put some work in. Usually it's the third time.
You're trying to talk yourself out of business here, by the way, to people.
I know. The third time, it's, what were you saying?
Oh, really?
Yeah.
Oh, okay. Okay.
But that's what I find in practice. It usually takes 3 big flares. And then they're like, what were you talking about? Because now they realize it's not just going away. It's not the quick fix.
Okay.
Right? But that's just my experience. So
I like that. That's just a good social post. Your third big flare.
But ideally, they get it the first time and they avoid the other,
I was thinking maybe because what we teach is like, it's not, if we could find a way to make it more exciting.
True.
It's like, people go, Now, I love holding isometric positions, connecting with my lower trap, I like it.
Yeah.
But it doesn't look like anything you'd want to do.
Yes.
And it also doesn't look like anything's happening. It looks like they're doing that right now.
Yes. Yeah.
I'm just like, how can we flash this up a little bit?
How do you make it sexy?
How do we make this sexy? Why try to get like cute models and cute people doing this thing and getting excited about it? It seems to be helpful.
Yes. Yeah.
It seems to be.
So to that point, my answer would be the more that you can help them feel it. Because like what you're talking about, right? If you work on your positioning and your activation, when I have that position and that nice isometric, I feel the connection to my core. I feel, this huge activity, and it's like, this is cool.
Yeah, this is
cool. It doesn't look cool.
Right. But what's going on inside?
Back to how can we communicate it, or how can we help them feel it? Because if they can feel it, then they're going to be like, this is cool.
Yeah, how can we help them feel it?
Good question.
Well, I try to paint the muscles, and but I can still do better.
Yeah, you're bringing the awareness.
How do we help them feel it better? Because you know what it is. They'll be like, I've never heard this. I've never felt this before. I've seen all the people. This is the first time I feel it. We know once they feel it.
Then they're like.
They're like this.
Yeah. And that's, as a clinician, once they feel it, their eyes light up. And once you explain it to them, they're like, why has no one told me this? Right? Those combinations.
Yes.
Then they're like, when can I come back?
Right.
So So that's a good question. How do you help them feel it? I guess my answer would be keep trying to improve the communication, the illustrations. If there's opportunities to get them into more hands-on position to help them feel it manually.
Yes.
That's a big one.
That's where I want to move to
and
next.
a big part of that is finding the therapists, the movement specialists, the clinicians that have those tools to help them do that. But for the clinicians, and that's why I'm teaching. I teach domestically, internationally. I'm trying to train people up so that we have people to help them. Because all the time I get emails and messages, do you know anybody in this region? And unfortunately, going back to what you were saying, there's only, a dozen or so, I think more, I don't know the exact number, but instructors.
What's the prerequisite? What are the prerequisites to become a DNS coach?
So there's different tracks. One, there's an exercise sport track, and that's 3 different courses. There's a exercise sport 1, exercise sport 2, and then the third one is like a certification course. And that's open to both clinician, movement specialists, strength and conditioning specialists. There's also a clinical track, A, B, C, and then D. And that's more, both of those you get assessments and the specific exercises, and you learn how to facilitate that deep stabilization. The clinical side is more hands-on. So clinicians that are more manual, you learn more manual techniques. The exercise sport, you're learning position, you're learning some manual things, different cueing to help create that coordination. There's also another track, those people that work with pediatrics. There's a whole pediatric educational series. So
it's like a TPI structure where
it's similar, yeah.
How many clinical, how many coaches, or how many of these DNS practitioners certified are in the U.S.?
Not enough.
No. How many?
Good question.
Like 500, 200?
I don't know, maybe not even that much.
Man, I'm just like, after all this stuff that we're talking about, I've gone so back. I think the DNS is to me, it's the most solid model that I can wholeheartedly promote.
Right. It's a foundation it's a foundation of concepts and principles, assessment, active exercises, manual methods that are not meant to say, just do this and not other things that you're doing. It's meant to integrate nicely into whatever you're doing, whatever manual method, whatever training method. It's designed to upgrade the software, right?
Right. Upgrade the software.
It's just something to enhance the good work that you're already doing.
I mean, it is DNS. I mean, because the way I teach, I go, look, what we're doing is like, yes, we're going over teaching you how to hip hinge, we're going over breathing, we're going over scapular position, but ultimately, you're going to up those skills are used in whatever sport you're going to be doing.
Yes.
You essentially don't even need to be doing any of these fundamental movements eventually, because they're going to be integrated into whatever it is.
Exactly.
You just have this, I love the upgraded software.
Yeah. So the goal is to train the person, train the patient, train the client to first get the feel. And then it's like any movement skill, right? Like, let's say learning how to tie a shoe. At first, you got to really concentrate. You kind of make mistakes. You kind of get it.
I still haven't passed that phase.
I work on that too.
I still have the damn double bunny ears.
Right. But as you practice, it gets easier. You don't have to concentrate as much. Eventually, you're like talking to your friend, you're tying your shoe. So it becomes integrated into, remember, the subcortical region, where it just becomes automatic. And because those patterns are inborn and ingrained in there, if you help wake them up, if you help train them, now they're able to express themselves.
Right, they're not new.
They're not new.
Right, because every kid's got a hip hinge when they're 5, 4, the amazing hip hinge.
They're just, you watch an infant and that they're just, perfect support, perfect alignment. And
It's like blowing the dust off of it. It's not new. I love that. I've actually never thought of it that way. We've had them.
We have them. You and I still have them. We have different proportions, right? Our head size is proportionate to the body. Our shape of our rib cage, our limb length is different than the infant, but we still have the same motor patterns, and we still have the ability to express them. And when we do that, we can get back that movement efficiency that we had during the first year of life and those developmental milestones. And if we can do that now as adults, we move better, and it enhances either rehabilitation, but also performance. So the big thing, like Professor Kolaj, and the thing that really piqued my interest with Prague School is my background was, sports, and I enjoy treating athletes. Kolaj was treating he treats the Czech Olympic teams, hockey, soccer, tennis, and all these, amazing athletes, European athletes, because you improve their movement efficiency, you decrease the chance of injury, you increase performance.
Well, I've always said that this was, if we can look at a scale where it's basically a diagonal line, in the bottom of the line, bottom left is debilitated pain, can't even move.
Right.
In the other end of that scale is absolute peak performance for that individual. And it's just like, you're on the scale no matter what.
Yeah.
The further you are away from this pain, the closer you are to the peak. And the further you are from the peak, the closer you are to the pain.
Yeah.
I mean, there is a ground zero line, which is pain above and below.
Right.
None above and below,
Right.
there is.
And if you figure out and you can feel the right things to do, you stay above the pain line.
Right? At a minimum.
And
at a minimum.
You're more in the performance,
Yeah.
the fun part of it.
Yeah.
Yeah.
I say above the pain line is the minimum, but your body still could be degenerating, accelerated above the pain line. But you could always just kind of claw and stay one above it.
Yeah. Yeah.
But then we ideally get people enjoy and feel that, and they move into this integrative into these other.
And it becomes becomes like a movement practice, and
Movement
we call
practice.
it like a postural. It's almost like a postural Tai Chi.
Okay,
And
that's something.
One of my, especially with my athletes, is I will give them certain exercises and movements within the exercises that becomes their movement preparation before they go practice, before they go lift, before they go play.
Right.
And it could be 3 minutes, 5 minutes, 10 minutes, depending on what they need and what their activity is. Like before they go out to compete, maybe it's 3 minutes, light up the nervous system, light up the coordination, and then they go compete. First, okay, we're working on more fundamentals, and then we're going to practice or strength train. Maybe we spend a little bit more time. So again, you can design it and program it and dose it to, again, whatever the need may be. And not just the athlete, but the person who just wants to go walk for fitness.
Sure.
Or the runner, or the person who has to work, sit at a computer. If they have carpal tunnel, if they have chronic headaches, how do we help them decrease those symptoms so they can work, make money, support their family? So, which is even more important. Not that with pro athletes, they're performing to make money, but someone who has to perform to earn a living, that's even more reason for them to.
Sure.
This.
Yeah, and I call it part of their warm up, but I like the movement prep warm up.
Yeah.
I don't think it's like getting a name too that catches people's attention, at least in my world. Oh,
Yeah,
I need that.
Right.
Get them to say that.
Yeah.
Or even myself, like when I still do, but not as much, but when I tore my labrum, I no matter what, before I went mountain biking or anything, I mean, I had to take myself through my scapular work. I had to take my through some breathing just to get the right muscles turned on, so I could stay connected with them at a more rapid pace during my ride.
Right.
And it's like
same concept.
Same concept.
Yeah.
Man, this is awesome. I think we got to wrap it up actually, though.
Cool.
What I want to know is like maybe you could share with them about like we'll put in the comments too how to find you, because to get certified through you would be awesome.
Right.
And I'm thinking about it too. I'm like, man, maybe I should get this thing done so I can get the full spectrum of this. I'd love to know that. Maybe when some upcoming, if you know when some upcoming courses are.
Yeah.
Website, like how else to stay connected with you?
Right. Website. I mean, do you want me to say?
No, write it down. I guess you got the web. That's fine.
I mean, I can give you all that contact. But as far as upcoming courses, in September we have an Exercise Sport 1.
Oh, okay.
That's in San Diego. It's at Symbiotic PT. They work with a lot of the professional baseball players. That one's in September. 2 days.
2 days.
The Exercise Sport are 2 days. The clinical ones are 3 days. Also in September, we're doing a DNS neurovisual integration. So vision training, integrating into what we call active exercises. Because that's another aspect of just awareness and training that's a big component of dysfunction. Next year in 2026, we have a clinical course coming up in May. So if you go to my website, rintalakyro.com, or Rintala Movement Designs, you'll see the listings.
Okay, the dates are on there too for everything.
For those who are not, in California or international, Prague School of Rehabilitation, their website, they have a whole listing where they're teaching all over the world. And it's rehabps.com.
Okay,
and that's
we'll put
the
that down
Prague
there.
School website. When you go to courses and you see all the listings all over the world. So those are probably the two biggest resources as far as any coursework.
Any books maybe for people that might just want to start dabbling in this a little bit?
On the Prague School website, there's really clinical books. There's a whole research section that lists all the research that's been done, articles. There's really good articles that you can read.
Do you remember the book? I saw a book when I was in school, and I swear I still want to buy it. I don't know if it was the whole book, but it was basically it was definitely from Prague. It was about childhood development, infants. They were like holding the infant up by one leg. There's another one where the infant's on the ground. They're like pulling them. They're basically infant patterns.
Right.
Do you know what book that was offhand?
Not off the top of my head.
No. Okay.
But if you go to those resources, or if you contact me directly, there's certain articles that I always will give to people that has just what we were talking about. And then, social media, I'm on Instagram. I have different videos, information on upcoming courses. Okay. And that's Rintala Movement Flow.
Yeah, I'll link all that stuff below.
So there's different ways to kind of either find me or find coursework. And then, of course, what you have and the information that you put out is excellent place, because with whatever you do, you're integrating, whether you know it or not, you're integrating these concepts and principles. As far as, you wanting to maybe dive into it more, the more you understand it, and especially the more you would feel it, like in the courses, we help really people feel it, the better you'll be able to explain it. And that will help with your cueing in what you're doing, basically.
Do you know the dates in September off chance? I know I'm being lazy. I could just wait.
Yeah, September 6th, 7th.
Okay.
Is the exercise one. And that's a fundamentals where you get the assessments, the exercises, the concepts and principles. So that's a great starting point. But there's nuance to the process. The more you understand and can communicate that nuance, the quicker you can help the people you're working with.
And I want you guys to know too at home, it's like the nuance. I hope one thing you pick up out of this is that this idea, this movement, alignment, this world that we're speaking of, I mean, you're probably 30 some years into, it's 20 some years into the depth.
25 now practicing. Yeah.
25 practicing. Right. Yeah. That's just practicing. So the point is, this is like the depth of this, because a lot of people go, I've done this exercise, I've done this. I'm like, how dare you say that you know? Yeah. When just the depth of this and connecting is like,
Right.
there's so much depth to movement. There's the science and there's art underneath it. I mean, it's its own. And when you dive in, there's so much underneath. And I really just, hope you guys really understand now this isn't surface level exercises. There's depth, there's connection to movement, there's connection mind, body to this. And there's ways, and then integrating that back into life. It's an awesome process. And I think it can save your life.
Yeah.
It can make you feel more confident.
Yeah. Improve your life, improve your quality of life.
Oh man, guys, it's such an investment. Even like 6 months of this will pay dividends for the rest of your life in terms of your physical ability. So I appreciate you guys being here and staying tuned. Dr. Rintala, nothing but respect for you and everything you've done. And I've always looked up to you. And that's why I'm proud to share with you some of my concepts, some of my positional presence. Do you like it?
That's awesome.
Okay, good.
I love it. And thank you for the opportunity to talk about this. And thank you for the good work that you're doing as well.
Likewise.
You're helping people.
Thank you, as are you. And now I'm super happy to be in touch with you too again and be back connected.
Awesome.
All right, guys, thanks for tuning in. Fix your shit.